We have helpful guidelines from Radar on how we should be monitoring patients with imaging while they are on therapy. We know that a significant number of patients will show radiographic progression without other clinical or significant PSA signs. There's data that shows that 1 in 8 patients progressed with a PSA less than 2. For those patients that seem to be responding well to therapy and have a stable PSA, I still strive to image them yearly. And for patients that have a rising PSA, I image them more frequently as the PSA rises. We know that progression is going to happen in almost all patients with metastatic prostate cancer. So while we typically see a PSA rise as our earliest sign of disease, that's not the only way that patients do progress. That would represent biochemical progression, and it's certainly most frequent of all. But we can also see progression radiographically, which would be visible on imaging, or clinically with new symptoms related to the cancer. We know that a lot of patients now are being diagnosed initially with metastatic disease based on more advanced imaging, which is PET-CT, also known as targeted precision imaging, or TPI. And although this is really helpful to have, it means that we're identifying patients with much smaller disease. That may not be visible on conventional imaging. So as we see patients progress and we see the PSA rising, I don't believe we should have a lower limit to what that PSA should be to allow us to do PSMA PET imaging or TPI. So my goal is to always understand the stage that the patient is in most accurately on a regular basis. So if we're seeing signs of the PSA rising, especially in patients that may be on therapy and showing signs of non-metastatic castrate-resistant disease where we haven't identified the site of progression yet, I definitely want to use the PET scan fairly early in that progression and then regularly as the PSA continues to rise to help get the most accurate information. Once again, we're trying to identify patients early on as they progress and accurately stage them and place them in their accurate risk groups. So we don't want to hold back our best tool, which oftentimes is imaging. We also want to be regularly asking patients and not ignoring new complaints that might be pain or other new complaints that might be related to progression of disease with more sites of disease that may just be clinical progression that wasn't showing up initially on PSA. It really is essential to be regularly keeping up with our patients, regularly reassessing with our patient's status, because the whole nature of these multiple options that we now have for treatment is to identify the right treatment for the right patient at the right time. And oftentimes that means identifying patients earlier in their progression.
Indication: Provenge, sipuleucel-T, is an autologous cellular immunotherapy indicated for the treatment of asymptomatic or minimally symptomatic metastatic castrate-resistant hormone-refractory prostate cancer. Important safety information. Acute infusion reactions. Acute infusion reactions reported within 1 day of infusion may occur and include nausea, vomiting, fatigue, fever, rigor or chills, respiratory events, dyspnea, hypoxia, and bronchospasm, syncope, hypotension, hypertension, and tachycardia. Thromboembolic events. Thromboembolic events, including deep venous thrombosis and pulmonary embolism, can occur following infusion of Provenge. The clinical significance and causal relationship are uncertain. Most patients had multiple risk factors for these events. Provenge should be used with caution in patients with risk factors for thromboembolic events. Vascular disorders. Cerebrovascular events, hemorrhagic ischemic strokes and transient ischemic attacks, and cardiovascular disorders, myocardial infarctions, have been reported following infusion of Provenge. The clinical significance and causal relationship are uncertain. Most patients had multiple risk factors for these events. Handling precautions. Provenge is not tested for transmissible infectious diseases. Concomitant chemotherapy or immunosuppressive therapy. Chemotherapy or immunosuppressive agents, such as systemic corticosteroids, given concurrently with the leukapheresis procedure or Provenge, has not been studied. Concurrent use of immune-suppressing agents may alter the efficacy and/or safety of Provenge. Adverse reactions. The most common adverse reactions reported in clinical trials, greater than or equal to 15% of patients receiving Provenge, were chills, fatigue, fever, back pain, nausea, joint ache, and headache. Please see full prescribing information on Provenge.com. To report an adverse event, please email our pharmacovigilance department at drugsafety@dendrian.com or fax adverse event details to 833-464-0123. Please provide details pertaining to the adverse event and provide contact information so that our pharmacovigilance team may contact you with any questions. To report a product complaint, email our quality department at cqacomplaints@dendrian.com. Please provide details pertaining to the quality issue and provide contact information so that our quality team may contact you with any questions.